Hotbed Talk.
Hello, my name is Jillian Dirkes, and I'm the Program Manager of the Duke Smoking Cessation Program. And today, with my colleague Andrea, we're going to be presenting implementing tobacco use treatment in perioperative settings using the RE-AIM framework.
Hello, everyone. I'm Andrea Pratt. I'm a licensed clinical social worker, tobacco treatment specialist with the Duke Smoking Cessation Program, and I practice within Duke's pre-anesthesia testing clinic.
We have no disclosures to report, just an overview of where we'll be going today. Smoking cessation has significantly positive impact on perioperative clinical outcomes, and there are effective tobacco use treatments. And the main barrier to offering patients effective treatment is really the lack of well-implemented tobacco use treatment services. There is no one-size-fits-all solution that is going to work for every clinical setting, for every hospital. And so what we're going to offer today is a framework called RE-AIM, which is a way to think through implementation of a tobacco use treatment program. We're going to talk about the decisions you would need to make to set up a program like this, including some of the pros and cons. We're also going to reflect on our experience at Duke setting up a tobacco use treatment service in a perioperative setting. We opened our clinic in 2018, and so we'll reflect on what has worked and what hasn't. The smoking in surgical patients is associated with poor surgical outcomes. There's an increased risk of cardiac arrest, pneumonia, infection, 30-day postoperative mortality, and more. And quitting smoking even a couple of weeks before surgery will reduce the likelihood of respiratory and vascular events. And for those who quit even closer to surgery, a few days, a week, it doesn't appear to worsen those clinical outcomes in comparison to those who continue to smoke. And abstinence at any point in life is going to have profound health benefits, and surgery can really be a teachable moment, especially when there's a hospitalization associated with it. That sort of forced abstinence can get patients through those early withdrawal symptoms. For more discussion about the clinical aspect of smoking in this population, I'm going to direct you towards a review paper that we wrote in 2020, which I've cited here at the bottom of this screen. There is effective treatment for tobacco use. It includes medication and behavioral strategies, but even brief counseling can really move the needle for patients. However, knowing that there is effective treatment isn't enough because the implementation of this treatment doesn't happen. A really great example of this, good evidence-based practice that is not well implemented is the 5 A's. Many of you may already be familiar with this. It's, ask every patient about tobacco use, advise they quit, assess their motivation, assist with medications and counseling, and arrange for follow-up. Very simple, can be implemented briefly, and has been taught very widely to healthcare professionals as a way to offer this treatment. However, when we evaluate how well this is implemented, we see for those patients who see a primary care provider each year, less than half report being advised to quit smoking. So even getting to this second A, and 25% report receiving some sort of counseling or medications, which is this 4th A. So the treatment is there. There's an option available. It's brief. It's low cost, but it's not being implemented. So today, Andrea and I are going to talk about the RE-AIM framework. So rather than only focusing on effectiveness, we're going to look at 5 elements that will support implementing a tobacco cessation program. And these 5 elements came out of a way to measure implementation and have really become a way to guide implementation as well. The first element is reach. So reach is the absolute number of patients. So how many people who are using tobacco are you seeing in your broader surgical population? Proportion that you're treating, and representativeness of the population. In the surgical space, one major concern is identifying patients far enough upstream. If we don't know that a patient is smoking, if we don't know that they need treatment, until the day before surgery, then we're not going to have as much of an impact as if we knew 8 weeks before surgery. A couple of things we can do to really work towards that to help identify those patients farther upstream is asking patients at every visit about tobacco use and documenting that in a discrete field. Also making sure we're reassessing people who are listed as former smokers or former tobacco users, because relapse is is a normal part of tobacco use, and it can happen even years after cessation. And training staff, your intake staff, on assessing this. So teaching them how to ask the question and where to document when they ask that question. Another part of identifying patients far enough upstream is recognizing that motivation to quit is not an indicator for treatment. There was a study done that evaluated patients who said, I want to quit smoking in the next 30 days, I want to quit smoking in the next 6 months, and I'm not interested in quitting in the next 6 months, and treated all 3 groups. And in 6 months, there was actually no difference in quit rates between the 3 groups. When we offer treatment to everyone, we see quit rates similar across all populations. Another part of REACH is this question of representativeness. So what does your patient population look like in comparison to those engaged in treatment? How do we engage a representative population in treatment? One way we do this is making sure we have pathways for people who we know will be coming in. Smoking and tobacco use is associated with psychiatric illness, substance use disorders, poverty, low levels of education, and health literacy. And so we need to make sure we have a pathway for treatment for those who have these disorders or who have these, or who are of low socioeconomic status. Also making sure we're prepared for those who are smoking light or intermittently. A little under half of all people who smoke cigarettes smoke fewer than 10 cigarettes per day or not even every day. And so making sure we are also treating those folks as well. Some strategies to work on for REACH. We have 3 strategies to really think through. One is having referrals from providers, so from surgeons, from your primary care staff, if you've got them, as well as from the pre-anesthesia teams. There's also best practice advisories, so having or automated alerts of some kind, alerting the treatment team that the patient is in need of tobacco use treatment. And then a third is proactive outreach or direct outreach to patients. So this is before a treatment team member has identified that the patient is interested or needs treatment, and instead is reaching out to those people who have a positive tobacco use sign in their electronic health record. At Duke, we're doing this through our patient portal as well as through automated calls, and we've also had staff make the calls directly to patients to offer them treatment. And Andrea, if you can talk about your experience with that.
Yeah, so I have participated in the Optout outreach, and that looks like what Jill just said. Any patient identified as currently using tobacco, and if they have an upcoming appointment in our pre-anesthesia testing clinic, we call in advance before their appointment with us to see if they want to schedule a tobacco treatment appointment as they're preparing for their upcoming surgery. We've received a wide spectrum of responses. Many patients accept and schedule the appointment, even thanking me for the call because this is something they've been thinking about doing for a while. Or I have patients who have been asked to quit smoking by their surgeons, and they just haven't been able to be as successful as they expected, so they'll go ahead and schedule the appointment. We also have patients that are ambivalent, and they know they need to quit and they want to quit, yet they'll tell me that they've tried every treatment option and just feel like nothing will work. And this really opens the door for me to be able to help explain how our program is specialized, ways that we can support them with quitting before their surgery. Some will go ahead and schedule an appointment with me. Others will let me know they'll think about it. I also have patients who are not considering any change. They'll tell me this time is too stressful with the surgery coming up. And at times I have people not interested in discussing this at all and have been hung up on, which doesn't happen as often as patients accepting the appointment. But we have learned that providing a variety of ways to let patients know about our services is helpful. And even if they decline, when we contact them in advance leading up to their pre-anesthesia appointment, they are aware of our service when they come in for the appointment, and they can discuss any questions or even schedule an appointment with us. I have found that most patients know they should quit before their surgery and they want to quit, yet their readiness in the stage of change is also important, as we see that some will schedule an appointment with us and others just aren't ready for treatment.
And we've done a study on this on our program at Duke where we evaluated these 3 different methods. And what we really concluded is that having different methods for reaching out to these patients is really important, because what we find is we reach distinct populations and we have different outcomes depending on how we're reaching the patients. The second element of re-AIM is effectiveness. Effectiveness is the impact of the intervention on clinically meaningful outcomes. And in tobacco use treatment, this is really cessation. How often can we get people to cessation? There are 2 types of treatment that have been studied in the perioperative setting specifically. One is a brief counseling. So 1 session, fewer than 20 minutes, just some brief counseling on how to quit. There's also intensive, which is more than 30 minutes of counseling spread over multiple sessions. Both lead to cessation in perioperative treatment, and intensive treatment is about 10 times more successful than brief. Whatever treatment model makes sense for where you are, it should include medications and counseling. Medication is going to address withdrawal symptoms and undesirable side effects of cessation, like weight gain. And counseling is going to help with the psychosocial challenges, stress, negative affect, other people using tobacco. And because both of these, the withdrawal symptoms, the side effects, the psychosocial challenges, can all lead to relapse and need to be addressed for a successful quit attempt.
I'll share a little bit about what we've learned in our pre-anesthesia testing clinic. Many patients that come to our program have complex health challenges and they've smoked for decades. And so helping them quit is quite complex. And as Jill mentioned, there's that physical component of addiction, the cognitive behavioral component of habit. And so we have found success with having patients meet with a medical provider first, getting the quit smoking meds prescribed and figured out for the patient. And then if they need some additional support, they're sent my way where I will provide individual therapy. Different ways that I've helped patients, meeting them where they are. I'll use motivational interviewing techniques when the patient presents with some ambivalence, kind of telling me they know they need to quit, yet they really enjoy it and they don't want to give it up yet. I'll also use cognitive behavioral therapy techniques to help patients process. This is a common underlying theme. Patients will tell me that they feel that smoking is calming, and we start to look at if they're willing to explore new ways to feel calm without a cigarette. We've also found that mindfulness skills are really effective with helping patients cut down or quit smoking. We'll begin discussing and practicing this mental skill, working together, of observing the urge, noticing the thoughts and feelings around it. Really challenging patients to start to change their relationship with smoking instead of getting lost in the experience of smoking. They start to notice what the cigarette actually tastes and feels like as they're inhaling and exhaling the smoke. Increasing their self-awareness of smoking actually helps patients break out of the automatic habit of smoking, and they'll end up telling me things like, I actually don't really like the way the cigarette tastes, or they'll start to consider, this cigarette doesn't really help me with my anxiety after all. One of my favorite questions to ask patients is, what do you like about smoking? And the conversation generally opens up to look at the function of the cigarette, why patients are smoking. And I recently had a patient being able to name that she copes with her anxiety by smoking. And we kind of walked through recent experiences, and she was able to name that her wanting to cope with anxiety is a good thing, yet she wants to learn how to cope in other ways. And she told me at the end of a recent session that being able to talk this out with someone has been so helpful, because she's usually just told to go and stop smoking, but she hasn't had the support to really think about why quitting has been so difficult for her. So we've really learned each patient, I guess, has a different set of needs, and our specialized program creates space to modify treatment, create a space for specific treatment plans for patients, and provide the individual support to help patients with this complex challenge. And this intensive treatment that Andrea has just described is our most effective treatment available. When you can offer the more sessions you can offer a patient, the more time you can spend with them, is our most effective treatment. At Duke, we're seeing, abstinence rates around the 30% mark. However, we've also found that not all patients are willing to engage in that intensive level of treatment. And so what we've had to do is offer a menu of treatment options. So our default is to recommend patients engage in intensive treatment. But if they're not willing to do that, we need to have other options available. So, a different example would be we've got brief counseling available. Our pre-anesthesia testing team might advise and prescribe some nicotine replacement therapy. We have a quit line available, which is available in all states in the U.S., which is just free tobacco cessation counseling by phone. And there are also other simple written materials or texting programs we may offer patients. And all of these are better than not giving patients any support at all, where their quit rates may be in the 3 to 5% range. The third element in REAIM is adoption. So these are settings and clinicians who deliver the program that are willing to initiate the program. So a couple of things to think about as you're attempting to get this started at your hospital is billing for services. So do you bill or do you not bill? Because the financial piece of this can often be what makes or breaks a program. So the pros and cons of these. With billing, you're going to need a licensed provider, which is generally going to be more expensive, but you are going to bring in revenue. However, billing is going to limit your patient population to those who have insurance. On the other hand, not billing means your costs are going to rise with the more patients you treat, meaning it's going to be harder to expand as demand for the service increases. But not billing is going to offer greater access to those who don't have insurance, and you can use non-licensed allied health professionals who may not be quite as expensive as a licensed provider. There's no right answer here at Duke. We have chosen to move forward with the billing model, and our federally qualified health center here that we're affiliated with has made the other decision that they're not going to bill for their services. The other thing, that is closely linked with billing is provider type. Who do we choose to offer this service? A multidisciplinary team is your best bet with capacity to prescribe medications and offer behavioral treatment. At Duke, like Andrea described, we have advanced practice providers like nurse practitioners or physician assistants who see patients first, and then they're seen by our licensed clinical social workers for individual or group treatment. In other institutions, they use sort of almost a reverse model where they have licensed or unlicensed tobacco treatment specialists who are kind of primarily treating the patients, and then they make recommendations to prescribers, whether that be the patient's primary care provider or maybe a medical director in their program. A model I want to maybe recommend against is a whole team model where it's every staff member's responsibility to offer tobacco treatment counseling. We offer it as every part of every visit. It is a great idea to advise and assist, connect patients to services at every visit. But as, a standalone treatment model, what you're going to find is there's going to be less consistency in treatment and less expertise on the team versus having dedicated staff to do this. The other part of adoption is getting buy-in from your referring providers and clinical staff. And Andrea, if you can talk about that experience. Yeah, I was here in 2018 when we came into our pre-anesthesia testing clinic, and with any change, positive or negative, it takes time and effort, and we definitely saw that adjustment period happen in our clinic. Our advanced practice providers, they are busy, and this was one new thing to their plate. And I think there was also the underlying question of, if I talk to my patients about this and refer them to the program, is it going to help our patients? Is it going to achieve the results that we want? And so we quickly went to work making our program marketable. We knew we were coming into an existing clinic, and so we wanted to build relationships. We worked to be as flexible as we could to meet their needs. We gave presentations about our program, why we're different and how our program works. We increased communication through the process, and slowly but surely we started seeing more and more referrals coming into our referral queue.
And the other part of adoption is really building this into your standard referring practices. So making it as easy as possible for referring providers to access the service. So an example here is this best practice advisory. This is the automated alert I mentioned earlier. And what you can see is it pops up for patients, recommends patient has been identified as a tobacco user and would benefit from treatment. And then down here, it says, it tells the provider, program referral recommended, and the order button is already pre-checked. So all they have to do when this pops up is hit accept and move on, and they've done what they need to do. And I want to offer this in comparison to what I've seen others do, where they may lay out a lot of questions for referring providers to answer, like number of cigarettes smoked per day, stage of change, are they pre-contemplative or ready, are they in the action stage? Leaving a lot of that out and making it very simple. Also thinking about how you make it a part of your standard pre-anesthesia screening. Just make it one of your questions you need to ask as part of that screening. The fourth element of REAIM is implementation, which is fidelity to model, including consistency of delivery, costs of implementation. And so as you're thinking about this, making sure you're measuring success in more than just abstinence. So how frequently are we offering standard of care? So how frequently are patients getting both medications and counseling? How many visits do patients complete on average? Because we know the more visits they complete, the more likely they are to quit smoking or to quit using tobacco. And so thinking about other ways you're measuring success. To keep costs low, especially implementation costs, you want to identify and engage any stakeholders early on. A big area we see people get tripped up is in the electronic health record changes. So working very closely with IT, getting your clinical champions on board, like Andrea talked about, making sure you're building trust, being flexible, and keeping them engaged throughout the process. If you're going to be billing, you'll probably want your compliance team, marketing, scheduling, making sure all those teams are involved early on. And Andrea, if you can talk about your experience with patients.
Yeah, so as we know, working with patients in theory and what it looks like in execution looks different sometimes. Some of the challenges that have come up with patients is just barriers of high copays, both with medical therapy visits as well as medication sometimes. And so we have worked to refer or link our patients to free resources, as Jill was sharing earlier, as well as free resources too with the medications, working through the trial and error of the side effects of the medications and getting patients set with that. Patient readiness, motivation, and confidence is also at play. And so we've seen that with patients engaging with our program or not engaging, as well as patient timelines. They're a little different than ours sometimes. While we have seen patients being able to quit smoking before their surgeries, others have not been able to. I have seen some positives come out of this, though, in terms of many of our patients have high with complex medical challenges, and so they aren't able to quit before their surgery, yet they are enrolled in the program and already working with me, and I noticed they have an upcoming surgery in the next 6 months, and so that becomes our new guide. We're working to quit before that next surgery. I'll also get patients that I'll start working with, and I think of a specific patient right now that I just met with recently. She had her surgery back in February 2020, and we are still working together about a year and a half later, and she ended up retiring in January 2020, had the medical challenge, unexpected hospitalization, and then COVID hit. And so she had a lot of barriers that she had to work through. And she has finally gotten down from a pack a day to 2 cigarettes a day. And she is at the place where she feels confident that she can do this. All that to say, her timeline was a little different, but we've continued to work together. And I'm confident she'll be able to quit smoking in her own timeline.
And the last element of REAIM is maintenance. So this is the extent to which the program is part of your routine organizational practices, as well as monitoring any possible reasons for discontinuance. One area of maintenance is really keeping your stakeholders involved. Your practice is going to evolve over time. I think COVID has taught us that our practices are really going to evolve, and they can sometimes evolve very quickly. And so keeping your stakeholders involved can help you remain flexible in these changes. You want to offer regular reporting. So we offer updates to referring providers at the patient level. Thanks for the referral. Here's when they're scheduled. Thanks for the referral. Here's the treatment plan, as well as at the program level. So coming back every 6 months and saying, here's how many patients you referred and overall what happened to them. Some programs will establish an advisory board, and also there's a lot of power in collecting and sharing individual patient success stories with stakeholders. Here you'll see an example of a newsletter. It's a kind of broad cancer care newsletter that comes out for Duke, where we featured one of our success stories on the front cover. And this is distributed to patients, but it's also distributed to all of our oncology providers so that they can see here's what's happening and what the patient experiences when I'm referring. Another side of maintenance is re-educating your referral service sources, as well as identifying places where turnover is going to require kind of regular education. So, we're usually about once a year going back to our surgical practices and saying, thanks for the referrals. Here's what happened to your patients. Here's some new things that we're doing. Please continue to refer. And we've also integrated education as part of our new nursing onboarding and our resident education. As a teaching hospital, we do get a lot of learners coming in, and so making sure those learners are just as aware as our permanent clinical staff as well. Some reasons we see for programs closing here are some 3 major ones we really see, which are low volume. Having an aggressive reach strategy, so reflecting back to that first element, is really important. Many programs struggle to get patients in the door, and so really starting aggressively early on is important. Having a provider leave can be really tough, especially if you're sort of a single person, one person providing tobacco use treatment in a clinic. Having that multidisciplinary team can protect you from that. And then also changes in funding. So, especially as hospitals go through ups and downs in revenue, really making sure you've got a sustainable practice model. And for us, that's why we've chosen to bill for our services rather than relying on pointing to downstream savings. So in conclusion, tobacco use treatment in a perioperative setting improves surgical outcomes and likely benefits overall health. Effective tobacco use treatment is intensive. It offers medication and behavioral support, and implementation of effective tobacco treatment in a perioperative setting is absolutely imperative. REAIM is a framework to plan that implementation and also to measure your implementation of tobacco use treatment in this setting. If you are interested in learning more, we do very regular trainings, including clinical trainings and implementation trainings, and you can visit DukeUNCTTS.com to learn more. And here are the citations, and thank you for listening today.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.